Good. Okay. Hey, everybody. Cody Barnett and
Dr. Doug
here at Bodyworks Physical Therapy and Concussion Center, and welcome to our seminar.
Our first one.
Our very first online live webinar. Good job.
Yeah.
Yes. So we've done lots of Facebook Lives and lots of videos, but this one will be a little longer, so it'll be interesting.
Yeah, be good.
It may be really good or it may be really bad.
Oh, it's gonna be good. Be good. We're gonna teach you guys about some
Find
stuff
out.
and help you guys learn and just answer questions. So if you could online, to make sure that you see us, put a thumbs up or emoji, happy face. Make sure you can hear us. If we need to make any adjustments for that, let us know.
We're getting some people online. We might give everybody about another minute or so.
And we want people to ask questions. If you have any questions about what might be going on or what what do you do, we can hopefully get to some of the questions and get people some information on taking the next step on what is going on with them and helping them out.
Diane Kellison says, hi guys.
Hi, Diane.
Hi, Diane. Thanks for logging on.
Oh, we had one thumbs up.
All right. So very good. So as you hop on, be sure and give us a little thumbs up or a hello there, something like that, just so that we know that you're there and you can hear us okay. And we're gonna get started here soon. So
Okay.
let's talk a little bit about who this is for. So what we really want to do and what we want to accomplish is we get asked literally, I don't know, hundreds of questions every day, either by patients or by email or by phone, and we really want to just try to put some stuff out there to answer the questions that we get asked the most commonly and give people some basic information about the most common orthopedic problem that people complain of in the United States, which is back pain. So that's kind of our driver for this, and just taking a lot of the questions that we get asked a bunch and kind of weaving them into this. So we hope that's helpful for people. While we're getting started, if you have any specific questions that you want to make sure we cover, or anything in particular going on, feel free to type that in the chat, and then that way we'll try to make sure and get to that. So who is this thing supposed to be for? What we'd really like this to be for is people that just have problems. So let's say, for example, you're a bit like me. You wake up in the morning and you got a stiff and sore back that doesn't quite want to move the way you'd like it to, and it takes an hour to kind of get moving and get it loosened up. Maybe you're having trouble doing things with your kids or your grandkids that you'd like to be able to do, and this is preventing that or limiting you in some regard. We want to have people that maybe can't do the things they enjoy, like maybe you're a golfer, maybe you're a tennis player, maybe you're a runner, etc., and it's either impeding your performance or keeping you from partaking in activities altogether. And then also people that just, to be honest, we get a lot of people that are fearful. People that come in our office that have fear of the future and what the future looks like if they don't do something about this problem. So if you fall into any of those categories, this is for you, and we hope you find it helpful, and please let us know if there's anything specifically in the chat that you want us to cover while we're talking. So basic statistics on back pain. What percentage of people get back pain?
I think 80% or so.
80% of their
people that will have back pain at some point in their life, whether that be when they're younger, when they're middle-aged, when they're older. And one of the most common things you see, even people just going to their family doctor, is back pain. And there's a lot of different arenas that back pain can come from, and that's kind of where we come in, because that's what we specialize in. We're kind of musculoskeletal dysfunction experts, and that's what back pain can have that origin, and that's where we can help you figure out what's going on and get some answers, and then from there, then we know which direction to go on how to treat it.
Very good. So I was just going to tell a quick story. Gentleman I saw just last week comes in and he is having difficulty golfing. And when we really get down to talking about it, he enjoys golfing, but what he really enjoys is getting to the 19th hole, so he can hang out with his buddies,
Yeah.
right?
Yeah.
And so he likes to golf, but it's really also about the social part of it, in that he gets to hang out at the 19th hole afterward, and that's something he's been missing out on.
Right.
And so being able to return to doing things that you want to do and be as active as you want to be and not have it get in the way of fun stuff.
Yeah, you don't want to stop early and to go to the 19th hole by yourself, while the other guys finish the golf round while you're just sitting there by yourself. So yeah.
So how we doing? We got any comments or things people want us to cover, or?
Well, Diane Kellison says she's recovering from an L1 compression fracture,
Ooh.
so she figured it would be a good idea to listen.
Yes. Those are bad. Compression fractures.
Compression fractures are a toughie. Those can take a while. You have to watch what you're doing. You want to be able to have good core strength in your abdomen and your trunk to be able to recover from that. Those can be a slow go. I've got one person right now that just had 2 compression fractures, and they had a kyphoplasty where they went in and they injected it, kind of raised it up, and doing much better, but then needs some strength and stability exercises to help get her back to being fully recovered. So you can't rush those. You have to, sometimes people use some type of support around their trunk, but pool exercises are really good, and Diane, that's right up your alley, so that'd be a really good avenue for you to rehab out of that. So, well, speaking of which, maybe we can go into some different causes of back pain.
Yeah, let's get going.
Okay. Here's one of my trusty spines here, and there's lots of different avenues of where back pain can come from. We see everything from muscle strains, where you have your spinal muscles that run down low, run up the sides. People bend over wrong. They pick something up wrong, and they pull a muscle, and then they move a certain way. That just hurts. That's pretty common. We also see disc issues. Disc issues are in between. These are the white things in between each of the vertebrae. And sometimes when you have a disc issue, it'll push it against a nerve root, and it will send pain down to the butt, down to the leg, sometimes past the calf into the foot. And what you see with disc issues is if the further down the leg the pain is, the more the disc is herniated out onto the nerve root. And so during treatment, you want to be able to work on getting the leg pain out of the leg and have it centralized. That means that disc bulge is not bulging out as much. If people sneeze or cough, those can be symptoms of like a disc issue. And they did a study where they put pressure sensors in people's discs, and they found out what position puts the most pressure on a disc. Interesting. Sitting is one of the highest ones that puts the most pressure on your discs. And so that's like a lot of people that we see in our office is people that sit a lot, and that puts a lot of compression on your discs. So that can be kind of a causative factor. So we talk about high-low discs a lot in here.
I've got a patient who has that right now, and hers is it's her right leg. So when she's driving and that leg is extended, and it puts tension on the nerve and gets her so sitting and driving.
Yeah, that's not fun. And then trying to get out of the car after that, it's like, oh, can't get out. Some other things people have, like what's called a torn. Well, don't need that one here. This is a disc.
What is that called? Is that a vertebroplasty?
Vertebroplasty. So, yeah, we had to take that one out. Vertebroectomy.
Vertebroectomy
is taking things out. Yeah, we didn't need that one. So that rolls into my annulus issue. So an annulus in a disc is kind of like a tree ring. Okay, it has rings in it, and sometimes in the middle is kind of like a jelly-filled donut, and then around that are rings in the disc. And sometimes that annulus, those rings can tear. And how you diagnose that is people have like a lot of midline pain, not radicular or pain that goes out to the outside, but pain right in the midline. And also with disc issues, with coughing, sneezing, that can really be diagnostic of an annular tear. So that's something that we see people have. Pinched nerves, we see if you see these yellow things here, these are the nerves that come out in between each vertebrae. Sometimes you get a bone spur in there, and a bone spur will push up against a nerve root and give you pain down the leg over to the butt. If you have a type of stenosis, there's two types of stenoses. There's a central one that goes around your spinal cord, and there's one that is the lateral. That's what's the nerve root. That's where the bone kind of grows around the nerve root. That's not a fun thing, okay? Especially spinal stenosis is people have trouble walking a long time, standing up in extension, and they're always looking for, they walk for a few minutes, 5-10 minutes, and they got to sit down for 3 or 4 minutes, and they're fine again, and they can walk again. That's another symptom of spinal stenosis. Trigger points.
Right, let's back up a little bit. So spinal stenosis, those people will have, so you just mentioned disc and nerve issues. That'll bother people more with sitting, that leg extended. Stenosis will be more with standing, walking, and that sort of thing.
And leg pain, both leg pains.
And generally get a little bit of improvement if they can lean forward or walk with a shopping cart.
Yeah, you see people that walk in the grocery store, and they walk like this with their forearms on the handle. It ain't because they're tired. It's because their back hurts. Seriously. Because I go, that's why I ask patients, I go, you ever go to the grocery store and lean on the lean on the grocery cart? They go, oh yeah. I go, it helps you walk longer. Yeah, because I can flex that spine and it takes some pressure off some of those nerves. So yeah, I see that in Dylan's all the time. I don't give him my card or anything, 'cause I know what's going on, but I'm not going to chase him, but I see that all the time. Trigger points. You want to talk about trigger points? You have good results with trigger points.
Yes. So trigger point is a small tender area in the muscle. Think of like a knot. You have a spot up in the shoulder or down in your rear end or in your lower back. It's like a knot. What we call a knot in our muscle is actually, the technical term is called a trigger point, myofascial trigger point. And so what those are, we'll see those really commonly either in these muscles that run up and down the spine here. If you're we need another vertebroectomy. So if you happen to be into hunting, it's the back straps on an animal is what these muscles are, but they run up and down the two sides of the spine here. That's a real common place for people to get trigger points, and basically it's a small localized area of pain or tenderness in the muscle, and it's got increased electrical activity, and so it stays irritated. And in layman's terms, it's sort of a miniature muscle spasm. Okay, very common area to have those through here, middle back as well, upper back, and then on our hips, probably, I don't know, at least 50% of what we do work on during the day is right here in the rear end muscles.
Right.
So our gluteus medius muscle comes down and attaches on the side of our hip bone. Our gluteus maximus muscle that covers our rear end attaches down there. And then there's some muscles across the back side of our hip that come off our tailbone called the piriformis muscle, and some other muscles that run in the same area. Very common places for us to have trigger points. Will cause some spasm and might even cause tightness. For example, a person that can't quite get their leg up like so to cross their, I don't know if you can see this, but crossing their leg over like so will be really, really tight. And then this is a really interesting muscle. This is called your iliopsoas.
Filet mignon.
Filet mignon again.
That's your filet.
But that runs up and attaches, if you'll notice on our spine, this is the front of the spine. And this actually attaches on our vertebrae on the front of our back, on the front side of our back, if that makes sense. Runs down through the abdomen, pairs up with another muscle right here on our pelvic bone, and then runs down and attaches on the front of our hip.
It does this.
And it does that, and very common area for people to have pain, and because it attaches on our spine, has a big relationship to our spinal mechanics. And because we do tend to sit more, that in majority of us, that muscle tends to generally be tight.
So when people are tight like that, here's how they get out of the chair. Oh, yeah. Oh, yeah. And take 20 or 30 steps, and it finally loosens up. That's one of the signs of a tight hip flexor.
So trigger points are very, very treatable. We see it all the time, and in fact trigger points can mimic some of the things that you were describing,
right,
that cause some of the pain that goes from the back, either central back pain
Right.
or radiating leg pain down into the rear end and down into the leg.
Right. A couple other things I want to go over. One's an SI joint. That's called your sacroiliac joint. Here's your back of your back. Here's L5 lumbar vertebrae. This is your sacrum. Then down here's your tailbone. This is your sacrum. This is your hip bone or your ilium. So your sacroiliac joint is right here. And this is I see this a lot. I just saw a kid today. He's got a hip problem. He's a football player, junior in high school, and he's got all this front hip pain. And it looked like he had a labrum issue in his hip, but actually his pelvis was rotated, and I derotated it, and then his hip pain went away. So the issue was right in here, but the symptoms showed up right over in here, up in the front of the hip. But the SI joint is another thing. They can't sit very long, can't stand very long. Got to keep moving, rolling over in bed. It catches wrong.
That's a lot.
Yeah, you just can't get comfortable. That's very common. Slow to get from sit to stand. Driving for a long time is not very good. And this sends pain down the leg and the butt to about the knee. That's kind of the SI joint, sacroiliac joint is. You see a lot of that. And then one of the last ones is your hip, because your hip here is related to the low back, where your hip motion, if you don't have hip motion here in the hip to be able to walk, what it's going to do is this is like stress engineering. This is real simple. If you don't get it here, the body's going to run it up to the SI joint, which has about that much range. Then it's going to start running up into L5, S1, and L4, 5. So when you walk, you actually start, instead of getting motion in your hip joint, you're actually taking it up in your lumbar spine. That's where you see the degenerative disc disease issues. I got a guy right now who's come in. He's got this back pain. And I look at him, and his back hurts, but the issue's coming from his hip. He can't flex his hip. He can't rotate it. We're getting on the hip, and he's got all those trigger points we've been working on, and he's like probably 60% better after 2 treatments. And he's actually walking normal now, but the root of the problem is here. But where does he hurt at? He hurts back in here. So that's one of the things that is key. That people go on the internet, they research stuff, and one of the things that Dr. Google, it can get you kind of in the ballpark, but you're not going to be able to figure out exactly what it is, because one of the keys that we see is you got to have a good physical exam, and that's what we like to do here. Is we're very thorough, is taking a good history and a really good thorough physical exam to either implicate, rule in, or rule out what's the root of the problem. And I think that's the key issue. Is we've had several people come in. I'm going to say lots of people that have seen therapists, epidurals, multiple physicians, other people, and then we get in here and we do our exam, and they go, "You're like the first person who's actually put your hands on me to actually examine."
Yep.
I go, "No one's done this? Have they done any of this or that? They've done this test?" They go, "No." They just listen to you, and then they give you some exercises, and we go, "Well, how do you know what's going on?" That's where we come in, and we've been doing this 29 years or so. And the key is you really got to get your hands on and do a thorough physical exam to figure out the root of the problem. I tell my patients this, you can chase symptoms all day long, but until you get to the root of the problem, you hit the root of the problem, the symptoms go away. And that's how you get very efficient with your treatment, is you figure out the root of the problem, and then the symptoms will dissipate.
Mm-hmm. So it's pretty common too to sometimes we call it the squeaky wheel.
Yeah.
There's something that's a squeaky wheel that's hurting. Maybe it's a spot on the back or a spot on a knee or somewhere else.
But is that the root?
But then there's other things going on mechanically. So
right.
Maybe an ankle is rolling too far in, or maybe a hip doesn't rotate in far enough,
right.
and then creates symptoms other places.
Yep.
But the root cause is we got to fix the ankle, or we got to fix your hip,
right.
and then the other stuff gets better.
Yeah, you look at all the different areas that can contribute to where that area is sore at, and then a lot of times that's where you'll find your root problem.
So that's a lot of information we just plowed through.
Yes.
Well, we do have a question from Don.
Yeah?
Which kind of relates. It says,
"What do you got, Don?"
"I've heard that sciatica is a symptom. How do you identify and fix the source of the problem? I think mine started with lower back pain issues just above the right buttocks."
Amputation, Don. Amputation is how we deal with that. No.
No.
He says, "Do you need to have an X-ray or MRI to really pinpoint the
That's a
root of the
great
problem?"
question.
A good question.
That's a great question. You want to take that?
Yeah, sciatica. Yeah, that's you're right. It's a symptom, but the question is what's causing it, And that can be, I mean, several different things. It can be a disc issue, it can be a hip issue, it can be a tight muscle. You know, we didn't even talk about your sciatic nerve. Your sciatic nerve is a nerve that comes out of your butt. If you hold your thumb up, that's how wide your sciatic nerve is. It's a big nerve, okay? That's how wide it is. It comes right out of your butt, and comes down the back of your leg. Sometimes people get a pinch here in the piriformis muscles, these back hip muscles, and pinch that nerve, and it sends the pain down the leg. Here's the other thing. I've seen this quite a bit, where you get back to the SI issue, where if the pelvis rotated, it kicks your rear end bone back, then your sciatic nerve bowstrings over it and sends pain down the leg. And a lot of times I take care of sciatica by just doing it. It's an SI joint problem, but the symptom is down the leg, but the root of the problem is here. So we see that. If you had an X-ray or an MRI, it'd be interesting to see kind of what the space is here. If there's any numbness or tingling, you know, what type of, we would ask, you know, what kind of symptoms, what's it aggravated by?
What things make it better, what things
make it worse. You know, that's also indicative of what can be going on with sciatica. But going through, those are some of the things that you think of. Trigger points can look like a sciatica, and that's where you have to get in there and, okay, let's check this tissue, this tissue, this tissue, this tissue, this tissue. All right, this one replicates it. Okay, boom, we know what tissue that hits with. This is probably looking at the root of your problem.
And so diving into Don's question a little bit more, because this is really, really common, is that, you know, we're not anti-MRI, we're not anti-X-ray, anything like that. But statistically, there's been several studies that have shown this. If you go out on the street and MRI 100 people, if they're over the age of 30, statistically, they're going to have at least one bulging disc. Okay? Yeah. And so if you just do a really, really thorough physical exam, you can nail down a lot of this typically just by a really good exam. And then if you do end up needing to have an X-ray and MRI, it should be to confirm what you found in your exam, not the other way around. Right. The other thing is that too frequently, and I've seen this literally hundreds of times, is that once they get the MRI and and let's say the MRI shows a bulging disc or a possible something that could be at play, if we don't correlate that to the way your symptoms are behaving, and we don't correlate that to what we find in the exam, that it's very common that people get told they have bulging discs, but they're not actually the cause of their problem.
It's not the root of the problem. I've had that lots of times.
You know, I mean, certainly sometimes it is, and it is, you know, the cause of the problem. But we don't want to put all of our eggs in that basket. We want to correlate any imaging stuff with a good exam and then a good history in terms of what are your symptoms and when they occur, and what makes them better and what makes them worse.
Yeah. You lay your radiology down next to your physical exam, and you want to make sure they match up. Okay. Sometimes radiology says this, but your physical exam says no. It's actually this, because when we check this stuff, there's no symptoms. But you check something else, you go, that's it. You go, okay. So this was just an incidental finding, but it wasn't the root of the problem. Yeah, I see that a lot. Next and
if you're again, by the time we're age 30, all of us have at least one bulging disc. We're already starting to get some arthritis in our spine, statistically. And then by the time we hit like 50, 60, those numbers go up, and it's sort of like gray hair. You know, like I've got one or two.
Yeah, this side. Yeah.
So we're all going to have some of that. The question is it consistent with the person's pain, and is it responsible for the pain?
Right. Right. So, any other good questions?
Hope that helps, Don.
Yeah.
Got any other things popping up there?
Not yet.
Okay. So in terms of what's next, so I wanted to tell a story. This is a very, very common story, unfortunately, and in our current healthcare climate, it's actually I'd say becoming much, much more common as time goes on. But this patient is somebody that I saw recently that is just completely indicative of some of the things that we run into, and a prime example. And that is, this is a lady who is pretty active. She's in her early 60s. We'll call her Susan. So Susan's early 60s. She's got some grandkids that she enjoys hanging out with and taking care of. She has a trip to Disney planned with said grandkids coming up soon, and had, for about the last 6 months, been having really, really bad rear end pain and pain down the leg. No low back pain, but pain in her rear end and running down one leg. And this person had gone, she's seen 2 different physical therapists, she's seen 2 different physicians, she's had 2 epidural injections in her back. She had an MRI that showed 2 bulging discs, and according to the MRI, said that there was some nerves being pinched. Okay, and so this has taken about over this 6-month time. All of this stuff has happened, right? And so she was recommended to us by a friend of hers who is a patient of ours. And when she came in and we did the exam, we looked at all of her radiology reports. We looked at all of her history. We did a thorough exam, and at the end of that, I had to say to her, Susan, like, I know you have all this radiology that says it's XYZ, but I'm not seeing that when we check you out.
Right.
And here's what I think it is you've got a lot of spasm in a muscle called your piriformis across your rear end. That muscle runs over the top of the sciatic nerve. Maybe if you want to show that. So this yellow right here is the sciatic nerve, and it runs across here, and the piriformis literally runs right over the top of that. And I said, I really think this is coming from these muscles in your rear. And we worked on it a little bit. And the first day we got some improvement. And what's really exciting and also kind of discouraging at the same time is that her quote to me was, "You're the first person that's actually examined me." Yeah. Right? So here this poor lady has seen 2 PTs, 2 different doctors, had 2 injections, had spent a couple grand on an MRI, and nobody has just examined her and put their hands on her. And that's really frustrating to me. It's also exciting when she gets better, but unfortunately in our current healthcare climate, there's a lot of that, and people just kind of get run through like cattle. So the cool part of the story is that within about a month, she's back walking, being active again. She's now babysitting her grandkids again, which she had to stop doing because of her pain. And oh, by the way, she's got this Disney trip coming up, and she was dreading the Disney trip. Now she's excited about the Disney trip. So it's kind of a cool story, but it ties in with a lot with all the stuff you were going through as far as getting down to the main.
I think that's one of the things we specialize in is we do quality work as opposed to quantity work. We just don't want to run people through like cattle. We want to give people answers and information and results, and we have the time to do that, and we take the time to figure it out, and we take the time to listen. We listen to what's really going on, and we have time to dive into and uncover the layers of the onion to figure out, okay, what's really going on here, instead of just going, oh, we got 15 minutes for new eval, take a 2-minute history, look at this, okay, here's some exercises, I'll see it twice a week for the next 4 weeks. No, we listen, we get in there and we just figure it out. And a lot of people come to us because they just go, oh, I just need some answers. What the heck is going on? Because no one else talks to me or no one else explains to me what's going on. That's what we do. We sit down and we figure it out and we explain to them and then take the next step. And they're like, okay, great, what do we have to do? So it's a lot of fun.
So a couple things. In terms of if you want to learn more, one of the things that we do have available as part of this seminar, and absolutely no obligation whatsoever, is we have an ebook that we put together that is basically 9 tips to help back pain and sciatica. 9 simple tips you can do. Anybody can do these, and you can download those. So Karen is going to be typing into our chat box a link to the back pain ebook, and so you can click on the link. It'll take you to our page. You can download that within a minute or 2 and get that going. So if you're wondering, okay, if you're kind of looking into the future and you're going, well, okay, what happens if I don't take action about this? this is a good place to start. And it just gives you some basic tips and tricks and things that we've learned over the years that we've compiled for our patients, and so you can take a peek at that. We doing okay? Karen got that up yet, or
Not yet.
Okay.
We have had a question.
oh, let's hit that.
We have 3, but we'll do the
Oh.
easy one first.
Okay.
Cindy says she missed the first 30 minutes. Will the video still be on your website?
That is a great question. We're gonna find out when we hit end.
Yes, hopefully.
So yeah, we're used to doing like 3 to 5 minute things, and so this is a longer one. We're about 90% sure that Facebook will leave it up on our videos page, so we think so is the answer. We think so.
We think so.
Yeah.
Okay, and then Don had a follow-up. He said, you may recall that I had right hip resurfacing, metal hip plant, nearly 7 years ago, and I've had recurring pain since then while doing impact activities. Recently had first full sciatica attack 2 weeks ago. Could my hip resurfacing somehow have caused this problem?
It could be a contributing factor. Sometimes it changes the mechanics, other muscles. I mean, when you have to go into the hip, you have to cut through some different muscles, and sometimes you see a little bit of weakness in those muscles that they had to make the incision through. So other muscles have to kind of take up the slack, and it can change your mechanics just a little bit. And sometimes just those little 2-degree changes over time can be something that are contributing factors on sciatica after a hip surgery, especially a total hip or hip resurfacing, stuff like that. Not as much as a scope, because they're going through the very small incisions, but anything where you have to make an incision through a muscle to get in a joint, that can be downstream a contributing factor to some sciatica issues.
So that answer is possibly.
Yes, possibly. It's in the ballpark. That'd be something you want to check out. So I'd want to check out mobility of different muscles, trigger points in different muscles, strength. We got our $1,000 muscle tester that gives us down to 1/10 of a pound, so we can check right to left to see if there's any asymmetries. And that's kind of what we're looking for when we use that, is we look and see if you're symmetrical or if there's like a big asymmetry. And if there's an asymmetry, then we know there's compensation patterns that go on to be able to make up for what you don't have in strength. Movement patterns, trigger points, hip joints take a little bit more of a hit, stuff like that. So that'd be something to look at.
Okay, and another easier one from Penny. She says, are these tips you are referencing good for preventative? No back pain yet, but don't want any either as I age.
It's a great question. That's actually the $1 million question of the night. The answer is yeah.
Ding, 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 ding.
Absolutely, absolutely. So yeah, go ahead and download that, and then just in general, it would be definitely helpful, and there's definitely preventive things in there that would help. And then secondarily, even though you're not having symptoms, pass it along to somebody else.
Yeah.
Pass it along to someone else.
And then last for right now, Polly asked, she said she had a coworker that had a pain in her front leg. She had back surgery. That didn't help the symptoms. And then somebody suggested a hip x-ray, found out she had arthritis, and she had a hip replacement, and she's doing great now. How often have you heard this before?
Yeah.
Lots. Yeah.
So it's hard to say without knowing more details, but again, sometimes people treat the MRI instead of treating the patient.
Yeah.
We like to treat the patient.
Yep.
So
that's where your differential diagnosis comes in.
Yeah.
Yeah. Yeah, we've seen that a lot. Any other good questions? These are great. We love bunny trails. We love questions.
While Melissa is scrolling through that, if anybody has any topics that maybe you'd like to see us do, we'd like to do these periodically.
Oh, yeah.
So if anybody has any particular topics that they'd like us to cover in the future, in
Neck
terms
pain.
of you know,
Plantar fasciitis is always fun.
neck, shoulder, plantar fasciitis, knees, hips, etc.
Yeah.
But if there's something else that you'd like us to have on our radar for the next one, let us know.
Yeah.
We have any other questions there, Melissa? Okay. All right. How are we doing so far? Give us a thumbs up or a thumbs down or a smiley face or a frowny face or something. Let us know how we're doing so far, and hopefully we're covering the ground that everybody would kind of like us to cover.
Yeah. This is intro information. You know, take the next step. Just, you know, learn more about maybe what's going on with you, and then what you can do about it. So I think downloading that ebook is a really good first start. You know, I tell people to go research stuff. I give them lots of information to go research, so then they understand and know what's going on and why. And when people can understand what's going on and why, well, then they make sense. It's like then they can take the next step. Because sometimes if they don't get their questions answered, they're hesitant to move ahead because they're not quite sure that they're making the right choice. And so if you have any questions about, you know, what we've talked about today, put it in the chat. We can get to them. And so it may happen, you know, something later tonight. Get back on here, type something in there. We can keep looking at it and reviewing it, and we can maybe, you know, get your questions answered.
The other thing that we see a lot of is people are just, frankly, they're just fearful of taking the next step.
Yeah.
So, for example, they don't want to make the wrong decision, or maybe they've made some decisions and seen some other practitioners that didn't work out the way they'd hoped, and so they're like, well, crud, I don't want to do anything about this because I've done this and this and it didn't work or it didn't help, and frankly, they're just fearful about making a wrong choice or a wrong decision.
Right.
So that's something too. If you fall in that ballpark,
we totally understand.
It's okay. We
totally
get it, and we've been there, and we've had a lot of patients in your shoes, which sort of leads to the other option is for sure if you'd like, download the ebook, and then the second thing is if you just want to chat on the phone, no obligation whatsoever. You just want to ask some questions, and we don't like to waste people's time or money. So one of the things that we offer because of that is we have a call request form that you can fill out on our website. You just, Karen should be posting that here shortly, I believe. But click on that, it just takes you to our webpage again, and we basically just kind of like set up a phone appointment with you, and give you a shout and talk it over, what's going on in your particular uniqueness of your situation, and then you know, let you know if we're the right people. We'll tell you. If we don't think we're the right people, we'll tell you that what our suggestion is. And so ebook, call request if you're interested in having that option.
Yeah, and I think for some other people that are on the next step down the road, so we do a lot of phone consultations, and what I tell people is I said, you know what, make one appointment with me. Just schedule for one visit. Let's sit down. Let's take a history. Let's do a good physical exam. Let's figure out what's going on and lay out all the information, and then I can tell you whether, you're a good match. Yeah, we could do this, this, and this, or no, you need something this, or you need to go up the food chain and get some more workup on this. I've had a lot of people do that where they just need somebody to sit down and just talk to them and explain things. And we've really figured out a lot of stuff. And sometimes it's not for physical therapy. Sometimes they need more workup, and it's the right next step to get them so they can recover and they can get better faster. But it's not in the physical therapy realm. It's somewhere else. And that's okay. Nothing wrong with that. At least they're moving ahead. But a lot of people, this is what they need. They need just figure out what's going on, why, get going on some treatment. And usually we're seeing improvement first day. Get your questions answered, and then we get a plan from there.
So let's see. If anybody have any further questions for us?
First off, it does appear as though we have interest in a plantar fasciitis webinar. So,
all right, plantar fasciitis.
I love plantar fasciitis.
Yeah, and then to expand on that, Debbie wants to know if plantar fasciitis can contribute to sciatica.
Ooh,
that's a good one.
That's a really good one.
That's a really good one.
Aren't you a smart one?
Or vice versa.
Or vice versa, because sometimes if you have there's a certain nerve root that comes out of your back, and it runs down your leg, and it runs right into that in the bottom inside part of your heel. And I've looked at people come in with look like plantar fasciitis, there's no symptoms in the foot, but when you go up the chain, when you start doing straight leg raises, start working up in the hip, they go, that kills my foot. And you do some treatment on the back, and then you go, my foot feels better. So it's actually coming from the back instead of from the foot. Yeah.
Or teasing out the other way is, do they truly have plantar fasciitis? And because they're gimping around, doing the I call it the Festus shuffle from Gunsmoke, doing, limping around on that leg, is that then causing some other mechanical things up the hips and the back that's scooping that up?
Yes, but that can, if you have a problem there and you limp off of that, then things change up the chain, and you can injure or wrench something else up in the hip, back, stuff like that. Yeah.
Very good question.
Good question.
Yeah. Somebody give her a thumbs up.
Yeah, you get 2 thumbs up for that question.
Yeah. Okay. Any other questions, Melissa?
None yet.
Okay. All right. So we're about 6:42. So, and then we'll kind of wrap it up there. Are we able to get those links up for people?
Mm-hmm.
They're up. Okay. So, if anybody has any other questions, type them in right now. We'll hit them. We said we were going to be done by about 6:45, so we want to be respectful of everybody's time and follow that schedule. So hit us up if there's anything else.
Has this been helpful for people? I asked that to a lot of patients. Has this been helpful? And I said, why has it been helpful? And people say, you answered my questions, or you actually listened, or you figured it out, or now I understand what's going on and why, and what I need to work on. So hopefully this has been helpful for you guys to answer your questions about where you're at and help to take the next step so you can get back to doing what you love.
Well, Penny and Don and Shannon all say thank you.
All right.
All right. Thanks, guys.
Some thumbs up.
Actually, thank you guys for watching. And
tell your friends.
We appreciate you being here with us virtually tonight. And we even have one special person who's here with us.
She actually came to the clinic
in person tonight.
Yeah. And then we go, it's online. She goes, whoops, okay. So she's right over here. Won't mention any names. Say, but she's a great gal.
But her initials are. All right. Well,
she's just so enthusiastic. She just wants to come in and learn. She's a learner anyway.
So thank you guys for joining us tonight. We hope it's been helpful, and we appreciate everybody's participation and comments and questions. And if you do have anything, as Doug was saying, that you can put comments in there, or contact us either through the Facebook page, through our website, phone number. I should give our phone number, 316-558-8808. And we just appreciate everybody showing up tonight. So thank you.
Don suggests that we provide free food for our guest.
We will for her.
There we go. There we go. All right. Well, everybody, thank you so much for joining us. And then we hope to repeat this. We'll figure out a schedule. We may do it monthly or quarterly. We're going to, this is our first time, so we may have stubbed our toe a little bit. We hope everything worked out well. Yeah, hope people enjoyed it. And thank you for joining us. Have a good evening.
Thank you.